Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Happy Good Friday, April the 10th. Thanks for joining the Wild Health Daily Update. As of this afternoon, Worldometer reports 488,905 cases and 18,000 deaths in the United States, and approximately 1.68 million cases worldwide and 101,000 deaths. We are not going to start the updates with these numbers from now on. While reporting on this and kind of the scope and magnitude of the problem is important, I don't think that we gain a lot of extra information by just reporting this daily. You can find those numbers elsewhere when we may talk about them, but I don't think it's a good way to lead into the podcast anymore. So next week, we'll be changing the format slightly, and we'll talk about that at the end of the podcast for just a second. Data from the Financial Times shows that there are early signs that new cases in the United States may be plateauing, but it'll take a few days to see if this trend will hold. New cases in the United Kingdom continue to plateau. The number of daily new deaths continues to rise in both the United States and the United Kingdom. As the early outbreaks in Europe and Asia slow down, new outbreaks are spreading rapidly in Africa, Latin America, and Southeast Asia. More than 50 countries across Africa have reported outbreaks, accounting for more than 11,000 cases and 500 deaths. The death toll in India is rising sharply as well. Although the official death count is upwards of 200, cases are likely to vastly be underreported due to the virus's spread through poverty-stricken communities with no access to healthcare facilities.
In U.S. news, in his daily briefing this morning, Governor Cuomo reported that there were 777 deaths in the past day in New York, bringing the total death count to 7,844. Although the toll continues to be high, there were 22 fewer deaths than the day before. In line with continuing trend of decreasing hospitalizations, the number of coronavirus patients in the ICUs in New York fell for the first time since the beginning of the pandemic, further indicating the outbreak is slowing in the state.
Therefore, we should open everything up, right, Mike?
No, not quite. A report obtained from the New York Times from the Departments of Human and Health Services and Homeland Security provides several case scenarios for how the outbreak could progress over the coming weeks. One model predicts that the country will see a new spike in infections if shelter-in-place orders are lifted after 30 days, further emphasizing the need to continue social distancing measures even as outbreaks appear to start slowing.
And those numbers were quite large. So right now, the numbers have been revised down to be about 60,000 deaths potentially is what a lot of the models are talking about. But if those restrictions were lifted, if we continued to have no school, social distancing, and we just simply lifted those orders, they were predicting around 200,000 deaths. So it's a big difference. So definitely not the time to lift those quite yet.
I was talking to somebody at work last night, Matt, and they were asking me the question, when do I think that our peak is going to come? They were specifically talking about Oregon, and I could tell they were referencing to like, is it going to be this week? Is it going to be next week? I don't think they were quite ready for my response of after we lift the stay-at-home orders and we have our second wave, which is what my guess was. I'm pretty concerned about this. I'm concerned that society isn't really, because the numbers are lower than the initial models predicted. I think that's going to cause people to get more cavalier, not adhering to stay-at-home orders, probably governors negating stay-at-home orders. I mean, you already heard about Kansas. The legislature basically reversed the governor's order to prevent stay-at-home from including church so that people could go to Sunday services. So I'm just worried that as a society, everyone's getting a little frustrated. They're a little tired of staying home, and I feel them. I am too. This is hard, but I'm concerned that it's going to turn into everybody trying to get back too quickly, not doing it in the right way, and then we just get a second wave that's as worse as the first.
Yeah, and I think the way you talked about this with your colleague about Oregon specific is important to note, because if a lot of the models, or some of the models, some of the more popular ones, are talking about the peak being today, like right around today, yesterday, tomorrow. And that may be the case, but we're talking about a national peak as this has kind of burned through some of our bigger cities. So the areas that haven't been hit as hard, where there's definitely hardly any probably antibody positive or people with immunity, we're going to hear, quote unquote, we've hit a peak and we're on the downside, but that doesn't mean we've hit a peak everywhere. It's going to be different area to area. So I think there's a little bit of concern about people hearing what's going on nationally and thinking it applies locally, and it just doesn't. It's not as bad locally in some places. We also just haven't hit the peak in some places. It's going to be different place to place. So this really should be a local decision. Having some national guidance is great, especially on the stay at home in general. But when it comes to opening back up, I think it's got to be area to area specific. I would say state to state, but it may be even more regional than that.
Yeah, maybe so. Matt, do you remember that app that the Singapore government created for contact and trace?
No, but I bet you're getting ready to tell about the Apple and Google announcement.
Yeah, well, I was going to say, did you hear about the one the U.S. government made? That's because they haven't made one. Apple and Google, however, are stepping up to the plate and have teamed up to build a software that can contact trace. So Singapore did this early on, and a lot of people think it's a big reason why their contact and trace program was so successful. Basically, it's going to use an opt-in program. So not everybody, it's not required, but if you'd like to, you can opt in and basically get an alert if you come in contact with a person with a known coronavirus patient. So basically, it's going to be opt-in, and you're going to be able to get an alert if you come into contact with a known coronavirus patient. Now, this requires that people sign up for it, and then they let basically the system know that they tested positive so that people can trace you. But it could potentially be great for this whole concept of contact trace that we've been struggling with in this country.
So I didn't get to read the whole thing about this, but are we going to have pranksters just reporting that they're positive to freak everybody out?
God, I hope not.
Know.
I hope not. I hope this doesn't turn into Facebook or Instagram.
I'm sure that Apple and Google have thought about that, but that's the first thing that came to my mind. If it's all self-reported, there's a lot of danger there.
Yeah. Why was that the first thing that came to your mind, Matt? So in literature today, wanted to talk about one article that is short and to the point. This was in Clinical Chemistry, released on April the 4th, called Potential False Positive Nucleic Acid Testing Results from SARS-CoV-2 from Thermal Inactivation of Samples with Low Viral Loads. So in this one, they took patients or samples with fairly low viral loads that would typically test positive, and then they heated those samples at 56 degrees Celsius for 30 minutes. And Matt, 56 degrees Celsius is around, I think, 129 Fahrenheit or something like that. So it's fairly warm, but not crazy warm. I mean, definitely what you could get in your car, for example. They found that 46.7% of those samples then tested negative after heating the sample. So I take this in two ways. One, you got to take good care of the samples as you're transporting them. That's not something that can just sit in your car as you stop, at the grocery store. Hopefully nobody's doing that. And two, I think it's helpful for information regarding deactivation of the virus. We've heard lots of reports about heat deactivating the virus. And here we're basically seeing that, once positive RT-PCR samples that, would otherwise have tested positive are now negative after, heating for 30 to 60 minutes at 56 degrees Celsius or around 130 degrees Fahrenheit. So I think that could be somewhat helpful.
Another study that I think probably needs a little bit of translation and explanation because people are going to be reading it is a study from a couple of days ago. The title is PCR Assays Turned Positive in 25 Discharged COVID-19 Patients. So in this study, this is a recent study from a hospital in China. They found that about 14% of the discharged COVID-19 patients tested positive for viral particles again about 5 days later. So all the discharge patients were sent home to self-quarantine for 14 days after they'd had 2 negative COVID-19 test results. And these were separated, I think, by 24 hours. Yeah, by 24 hours. The conversion from negative to positive result after discharge then prompted these patients for a second hospitalization, despite no real return of symptoms. Some of them still had a dry cough and things, but they didn't have the bad symptoms like they had before. The readmitted patients were then cleared of the virus within an average of 3 days. So this is going to be really important when establishing proper testing timelines to reduce the risk of discharging asymptomatic carriers in the future. So we need to just talk a little bit about what this means, because we're starting to hear a lot of people talking about return to work protocols and how testing has to be scaled up, and it does have to be scaled up. We have to understand how to use the testing, because in this study, in these patients, 14% of these patients had 2 negative tests separated by 24 hours, and they still tested positive later, so they still had some virus. This is a really interesting study, I think, for anybody looking to do event medicine or trying to do large-scale events in the future, and they think that testing is going to be the solution. So we would expect some of these patients, for example, in the hospital who were positive, to potentially have 2 negative tests and go home, because if you think about the operating characteristics of the test, if we think that this test is 75% sensitive, that means 25% of patients who have the virus are going to test negative. So if you then do a second test and 25% of those 25% who tested negative are also going to test negative, then you're talking about around a 1 in 16 or around a 6% of those patients would have 2 negatives. Now, this study had twice as high of a result of patients who tested negative twice than I would have expected. And I don't know what that means. I don't know if it's an issue with the sensitivity of that specific test or collection or what it is. But we know this is going to happen. This was just at a higher rate than necessary. Now, what does this mean, for example, if you want to get 1,000 people together? So we're going to go through a little bit of math on testing, and this would be better if we were doing this, you could see the math. But I'm going to give you an example. So let's say the test has a 75% sensitivity and a 99% specificity. We think the specificity is really good. So 98, 99%. If it tests positive, it means you have it. So what does that mean? That means if you test 100 people, it doesn't mean you're going to have 25 false positives. This just means 25% false negatives. It just means 25% false negatives are the people that have it. So how many you're going to miss depends on the prevalence of the disease. If everybody you're testing has it, which was the case here in China, then you're going to miss a fair amount. But that's not the case. Let's assume a population prevalence of 1%, for example. So because these are people that are healthy, no fever, no symptoms. We're talking about a large gathering of people. So we're going to say a low prevalence, say 1%. And right now in the U.S., there are some predictions, even though we say we have 500,000 cases, some people will say this may be vastly underreported, and it could be as many as 20 million with all the asymptomatic people. We don't know where it is. It's somewhere in that range. So we could be getting close to a 1% prevalence. I don't think we are yet, but let's just assume 1% prevalence. So of those 1,000 people, 10 people have it, and so some of those will test negative. So to make the math easy, let's say 1,200 people are coming into an event. If you have a 75% sensitivity and a 1% prevalence, the negative predictive value, meaning if you get a negative test, how much sure are you that it's right, is 99.7%, around there. So around 1 in 300 people coming into this event are going to be positive and test negative, which is what you don't want. So that's 4 people. All right, that's not great to have 4 people at this event who are positive. Now, let's say you do that protocol of 2 tests, kind of separated by 24 hours. Well, of those 4 that were originally positive, if we know there's a sensitivity of 75% and 1 in 4 are going to test negative when they have it, that's still 1 person. So you can see how the math works out with a test of 75% sensitivity and 1% prevalence in the population, 1,200 person event, you're probably going to have 1 person that sneaks through that simple testing algorithm of the reverse transcriptase PCR. So is that an acceptable risk or not? That's a question that the organizer will have to ask. What number is low enough? 100-person event with this protocol? What if you combine the serology and you identified some people maybe who would test positive for IgM and they would have had a negative PCR? Maybe that's what you need. Maybe it's just more monitoring and doing the testing protocol plus 2 or 3 temperature tests for everyone throughout the day. There are a whole list of variations to the testing protocols, but I just wanted to go through that exercise because I hear a lot of people talking about coming up with protocols to get people back together to either work or play or for whatever reason. And if you're coming up with those protocols, you have to have a good understanding of the statistics around it to design the protocols. And then obviously the execution is going to be extremely important. But this paper and study, I think, was something that we all need to be looking at, because if it is true that we're going to have more of these cases of test negative and then later test positive than we thought, that's going to come into play in the protocols as well. Matt, so Mike, was that completely useless rambling on the math and statistics?
No, at all? I wanted to jump in for a second and just sort of summarize what you were saying a little bit, just because I think the numbers were challenging to keep up with. I managed to keep up with them. The main point it sounds like you're trying to make is the reason this sounds so bad in this study is because we're testing patients that we know had the disease. So because of that, that's making the false negative rate appear bad, right? I mean, you're basically picking up all the false negatives because all the patients had the disease. Whereas if you're applying it to a population of patients who most of them do not have the disease, the number becomes very small. So it's 1 in 1,200, as you described, potentially. I think that this depends a little bit on what the true sensitivity of the test is. And my guess is that you're making up that number of 75% sensitive because we don't truly know what the sensitivity of the test is. I find it interesting that they had a 14% false negative rate there with 2 tests. That seems really high. So that makes me concerned that either there was some problem with the testing, or they had extremely low viral loads in these patients. Other things that we're not really talking about are viral load is important for how virulent that person is, so how likely they are to transmit the virus to somebody else. So towards the end of your disease, your immune system's doing a good job of fighting off that virus, and it could be that you actually have some of the components of the viral particles left over that test positive that still aren't virulent. So we don't even truly know if these people who've been discharged from the hospital now are actually transmitting the virus to people, or that whether they just have leftover particles that can show up positive on a real-time PCR. The other thing to keep in mind is this is not taking herd immunity into account. And granted, we're a long ways from herd immunity, but as we have more and more people in the population who developed IgA and IgM or IgM and IgG antibodies, we're going to be able to accept a couple of positive patients in a large scale event or something like that, because the population will be able to fight it off. So there's a lot here. This is not simple stuff, but it is an interesting article in the sense that that's kind of weird. I mean, is there 2 peaks of viral replication in these patients? Are we just having like these random 2 negative tests? It seems very strange, and their numbers seem high.
If I had to guess, another plausible explanation for this is that these patients in the hospital were being treated with multiple different treatments, as they were when you read the paper. And then when they're discharged, they stop all of that because they assume they're negative. So it could have been that there's such a low viral load, they're testing negative. They stop the treatments. The virus spiked back just enough to test positive, even though they're not really going to get sick from it necessarily. So that could have been the case as well. Another point about the events. So I guess the 2 points we'd make is, 1, it's not as bad as it sounds in the paper, but 2, we're also not necessarily as safe as we think just by getting massive testing, because there's a lot of other things that come into play when you're having a big group get together. But for example, the example I gave where you're going to have one person kind of sneak through the testing protocol, is that acceptable? So if you have all 1,000 people in a mosh pit at a concert, it's probably not. But if these 1,000 people are spread out over 200 acres and they all are 6 feet apart with physical distancing and they all wear masks, then it's probably fine. So it depends on the exact situation as well. So these protocols are going to be complicated. I just don't want people to get a false sense of security just because all of a sudden we have massive testing and can do massive testing. The operating characteristics, the prevalence, the exact scenario are going to be big drivers in what's safe and what's not safe.
Are you telling me I can't get back to mosh pitting anytime soon?
We could probably come up with a protocol for that, but it'll be a pretty strict and stringent protocol if you want to go back to mosh pitting. That'll be a podcast for tomorrow.
Matt, you mentioned that we're going to change up the podcast. You want to tell everybody about that?
Yeah, we're going to take a break this weekend. We've been podcasting every day for about a month now and releasing a couple a day. We think that everyone needs a break, and this is Easter weekend. We think it's a perfect time. We feel like you should be spending time with your family and loved ones and not listening to us talk about random research and literature and what are the new numbers. So next week when we come back, we are going to change the format a little bit as well. This is a dynamic situation that's constantly changing, and so we're going to be changing the format to do less reporting and more digging into the most important questions we're facing and a little more translating, just like we did with this last study. So we are going to release podcasts tomorrow and Sunday from the summit, but there's going to be no news updates for the next 2 days. So enjoy your Easter.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at Wild Health MD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.